Welcome to Perspectives on Neurodiversity, a podcast dedicated to challenging myths and assumptions about neurodiverse life. I am your host, Christopher Scott Wyatt, speaking as the autistic me and the highly distractible, hyperactive me. Followers of the podcast and blog know that my daughters and I have all been diagnosed with ADHD, Attention Deficit Hyperactivity Disorder. But what is ADHD? How can we better understand and support this form of neurodiversity? Joining us today is Dr. Walt Karniski, author of the new book, ADHD Medication, Does It Work and Is It Safe? Dr. Karniski is a developmental pediatrician trained at Boston Children's Hospital. He was director of the Division of Developmental Pediatrics at the University of South Florida in Tampa, Florida, for 15 years. He then opened a private practice and for 20 years evaluated and treated children with ADHD, autism, anxiety, learning disabilities, and other developmental differences. During that time, he developed and operated 3 private schools for children with ADHD, anxiety, and learning disabilities. Over the 40 years he has been practicing, he has evaluated and treated close to 10,000 children, conducted numerous studies of brain activity in children, and has been director of a child abuse program and a program for enhancing development in children born prematurely. Dr. Karniski approaches each child as a unique individual with distinctive strengths and weaknesses, where the diagnosis does not matter as much as understanding the specific needs of that child. His new book is ADHD Medication, Does It Work and Is It Safe? It is an honor to welcome Dr. Walt Karniski to Perspectives on Neurodiversity.
Chris, thank you for that beautiful introduction. It's a pleasure to be here today.
As I mentioned, myself, my daughters, we are all diagnosed with ADHD. And the first question I think everyone has who gets this diagnosis is, what is ADHD?
Great question. Most people describe ADHD in neurologic terms. And I recognize that ADHD has neurologic underpinnings, but I don't see ADHD as a disease. And let me explain what I mean by that. Let's imagine that we're back 100,000 years ago, and you are a caveman. Your job, you're living with a tribe of about 30 other cavemen with their families and children, and your job is to go out every morning and to pick berries for the tribe's breakfast. One morning, you're hunched over a bush and you're picking berries, putting them in your leather satchel, and all of a sudden you hear a rustling in the bushes behind you. What should you do?
Hopefully you react quickly.
And do what?
Boy, I think I'd run.
Okay. If you run and get back to the cave without the berries, the tribe's going to be angry at you for not bringing breakfast to them. So what I would recommend doing is turning around and seeing what was causing the sound. If it was a saber-toothed tiger, then you pull your knife or you run and you get back to the cave. You continue to have children and you carry that distractibility gene to the next generation. Distractibility saved your life. I don't see ADHD nearly as much a disorder or disease as it is an evolutionary difference. People that were excelling 100,000 years ago who were distracted at the right time were kept alive and able to spread that gene to the next generation. People that were not distractible died early and couldn't spread that gene. So the difference is that now we force children to go to school, unlike children who learned things in their father's blacksmith shop or learned it on their farm. Now they learn everything in school. They have to learn it in the way that the teacher teaches, which means sitting in a desk with their hands folded and their feet still, not turning around, not interrupting, and so on. So those children with that distractibility gene are going to have trouble in that environment, whereas they would have been the leader of their tribe if they had stayed in the caveman days. So I guess my position as a physician is I've got 3 choices. One choice is to invent a time machine and send the child back in time I haven't been very successful with time travel yet, so that's out of the question. Second potential solution is to change the way children are educated in the whole country. And I actually did attempt to do that by creating 3 schools for children with ADHD, learning difficulties, anxiety, and so on. What we did was teach the way the children learned, as opposed to most schools that expect children to learn the way they teach. The problem is that works for the 100 or 200 kids that attended our school, but it doesn't help the whole child when he gets to college age and goes off to college, or when he goes into the workplace. So the third option is medication. And the reason I use medication is because it works, whereas the other 2 options that I have don't work.
What you're saying, though, and I think this is how many of us feel who have ADHD, I have argued that schools are not designed for the neurodiverse, and increasingly our society wasn't designed for the neurodiverse. One of the things that we experienced as parents during the pandemic lockdown, homeschooling our daughters, I found that they did so much better, and I didn't see some of the problems that the teachers had reported to us, because we could adapt the learning to their needs. If they wanted to stand and work at the desk while going in circles occasionally, I don't care, we're at home. And the work got done. They were able to fidget. They were able to say, Dad, I need a break. Can I run around the kitchen island? And my answer to little Anne is, okay, Anne, if you want to run around the island, make a few laps. And then when she had made her laps and was happy, she would sit back down and do her work. Our schools and our workplaces, I can't do that. I can't get up from my desk at the university and go running around the halls. That's just, it's generally frowned upon.
Right.
But that's what I want to do. What I did learn was leave the office, leave the building, take a walk around campus with my thoughts, and then come back and write them down. But like you said, our students, especially our young students, can't do that. They don't have the freedom to say, I know what time it is still lecture time, but I really need to get up and move. We just don't permit that.
Exactly.
How do we approach this then, knowing that ADHD seems to be something that it's a detriment in the classroom and in the workplace, but as you said, at one time, it was an adaptation that served us so well. How do we bridge that and explain to teachers and explain to employers that we have strengths and we're valuable, but yeah, we're going to need a little extra tolerance?
There's a couple answers to that question. And one is that there's a number of studies that have shown that people who take medication for ADHD when they're children have less brain differences than people who do not take medication as children. And let me describe that. There research studies have shown that there are 3 areas of brain in children with ADHD that are smaller than children who do not have ADHD. Now, that doesn't necessarily mean that that's bad, but the 3 areas of the brain, their job is to focus attention, to avoid distractibility, to plan, to organize, to plan for the future. And if those areas of the brain are smaller and underdeveloped, they're not going to work as well. A number of studies have shown that there are differences in certain brain sizes in children. But the fascinating thing is if you follow them to adulthood and scan them again as adults, those adults who had been treated with medication as children but still have ADHD are doing far better in their life than people who did not have ADHD. And furthermore, when their brains are scanned, they found that those 3 areas of the brain that were smaller in those adults who had taken medication as children, those 3 areas of the brain were now normal sized. And in adults who had not taken medication as children, but were seen later as adults and having their brain scanned, still had smaller areas of those 3 areas of the brain. So basically what that's telling us is that medication may actually be enhancing the development of those areas of the brain and changing the brain structure over time, so that those behaviors are now similar to what they would have been if you didn't have ADHD.
If I understand what you're saying, it is that we can use the medication to, in some ways, make us fit into the classroom or the workplace. And that medication, especially in younger children, gives the brain a chance to better develop to what might help future success. So what we need to ask the teacher is, yes, my child's ADHD, but please understand that we're going to use some medication and we're going to try to help the child fit in, but please be patient. This child is different and needs time to mature and to benefit from those medications.
I think that's absolutely true. And they need time to benefit from the educational structure of the classroom. So they won't respond maybe the same as well the first day as they do a month later once they've gotten adapted to that program.
The title of your book, ADHD Medication, that first part, does it work? What you're saying is that the current state of scientific research is that there are benefits to the medication for children, those under 18 and younger, that the medication does have a lifelong benefit.
Oh, absolutely. There are 4 reasons why we know that ADHD medication works. And I can't go into a lot of detail with this because I probably devote 30 or 40 pages of the book to explaining these 4 measures of success. The first way of determining that medication is effective and that it works is that on the average, every year there are 350 research studies published. At least half of those studies focus on the development and behavior of children in the classroom on or off medication. And those studies show overwhelmingly that medication is effective and safe. The second way that we know that medication is effective is by looking at what happens to people when they become adults on the medication. And so, for example, children with ADHD have more trouble in school, they're retained more often, they're more likely to have lower grades, and they're less likely to finish high school and college. However, children with ADHD who take stimulant medication are much less likely to experience those educational difficulties. And as adults, we see that even to a greater extent. Adults diagnosed with ADHD as children are 3 times more likely to have been unemployed compared to non-ADHD adults. They change jobs more frequently. They earn less money than children who do not have ADHD. And we see this even in behaviors like driving. ADHD adults are more likely to have had traffic violations and more likely to have had a suspended license. They're 2 to 6 times more likely to have had a car accident. And when they do have an accident, the damage to the car is greater in people who have ADHD, indicating a more severe accident. But here's the amazing thing. All of those behaviors, all of those outcomes occur less frequently and to the same degree in people who have ADHD with medication as they occur in people who do not have ADHD. So what it really means is that medication taken as children, even if it's not being taken as adults, changes the way things act and interact with their environment and interact with other people.
Now, the question also in your title there, is it safe? You're saying these studies suggest either minimal or manageable negative consequences of medicating?
Yes, every medication has side effects. Even aspirin and Tylenol have side effects. That's true of the ADHD medications as well. Let me say this resoundingly clear. None of the side effects that occur from the stimulant medications are long-lasting. None of these side effects occur once the medication have been stopped. None of them are serious or life-threatening. And most of the side effects that do occur can be managed with a good knowledge of what is happening with the medication. And that's essentially why I wrote the book. I actually started with the chapter on side effects as the first chapter I wrote, because I felt that was the area that needed the most attention. The most common side effects are decreased appetite, difficulty falling asleep, irritability, mood suppression, an increase in anxiety if anxiety is present before. That's virtually it. We do see some cardiac changes, mild increases in blood pressure and heart rate, but not enough to be of any concern, and never have any of the cardiac side effects been shown to be dangerous in any way, shape, or form.
Over the last 2 years, we have seen, unfortunately, a greater politicization of medical care, especially vaccination. What used to be a minor problem in some communities has now become a major problem. We even see the reemergence of polio in New York City and parts of California. There was already some skepticism towards medicine in especially the autism community, but also to a lesser degree in the other neurodiverse communities. How do you go about changing this where, as you said, there aren't any lasting side effects? I was resistant to medicating myself. And then especially as a parent, I don't want my kids on too many medications. I constantly worry about this. And there are other parents saying, well, I would never give my kids any pill for any reason because that's changing them. I honestly reached a point where I had to sit down with the psychiatrist that we work with, and I had to say, my child feels horrible because she's failing in school. We need help. And we did find that medication has given, especially to Lee, the oldest daughter, it has just opened up a new world for her. She is a straight A student now. So how do we overcome those fears and those hesitancies other than anecdotes? And I know anecdotes are not data, but I can tell other parents the medication that I feared has actually been life-changing for both of my daughters.
Chris, you've really hit on one of the most important questions in this area. Let me tell you, I know you just made a comment about anecdotes, but I'm going to tell you a true story that occurred that I think explains why people are so fearful of medication, and yet once they start on medication, they find it so successful. I was in my office about 10 years ago, eating lunch, and I was reviewing the patients that I was going to see in the afternoon. And I noticed that there was on my schedule was the name of a girl that I had seen 7 years ago and hadn't seen since. And so I was curious about that. As she walked into the office, I said, "It's great to see you, but it's been 7 years since you were here. I diagnosed you with ADHD, and we started on medication, and then I never saw you back. What happened?" She said, "Well, my parents didn't want me on the medication. They were afraid of side effects, and so they took me off medication, and I never returned. And the reason I'm back is that I'm 19 years old now. I'm an adult, and I can make my own decisions. I'm a freshman in college at Florida State University. I know I'm a bright, smart person, and yet I'm failing all my subjects. I can't seem to get organized. I can't seem to do well in school." And so I said, "What happened when we started you on medication when you were 12, when I saw you last?" She said, "Well, the medication seemed to work. I got better grades in school, and I did well in school, but my friends told me I wasn't as much fun to be around. I used to be the center of the party. I used to be the life of the party. Everybody used to laugh and joke with me. And when I was on medication, I wasn't that way. And so my friends told me I wasn't as much fun to be around." So at any rate, we talked about that quite a bit. I started her back on medication. She came back 3 weeks later, and I said, "Well, how are things going?" And she said, "Well, they're going great in school right now. I've got straight A's. I'm spending half the time doing my homework, and I feel so much better." And I said, "Well, what's happened with your friends?" She said, "Dr. Karniski, that's the weird thing. My friends tell me that I'm a better friend on medication, that I listen to them, I don't interrupt. I seem to be more engaged in what they're saying rather than trying to express my own thoughts. And they say I'm just a better friend when I'm on my medication." So the question here is what happened to the girl that was 12 years old and hated the medication because it made her not as happy and as life fulfilling as she would have expected. And what happened to her when she was 19 and took the medication? What changed? Well, nothing changed in her. What changed was the expectations of the people around her. The 12-year-old friends expected her to be laughing and partying and doing silly and crazy things, whereas the 19-year-old friends wanted to talk about some serious things, what they're going to do with the rest of their life, their relationship with their boyfriend or girlfriend or whatever. And the world is different for adults than it is for children. And so in this particular case, she didn't like what happened to her when she was on the medication when she was 12, but the same medication given to her at 19 was life-changing.
That experience is so common. You feel different on the medication. You feel less outgoing in some ways, and yet you're able to do things and be more productive. That change when you're, as you said, when you're a 12-year-old or a high school student is different than if you're an adult. If you're an adult and you're able to accomplish your tasks and do things, especially at the college level, it changes things. So I think that's really important to remember, is that our expectations of what we want to be change as we get older, and the people around us mature, and their maturity also helps us.
Exactly. I one time saw a 9-year-old child, and the mother came in and described all the typical symptoms of ADHD. He had no comorbid symptoms. He had no learning difficulties. He just had hyperactivity and impulsivity and short attention span. So we diagnosed him with ADHD, started him on medication. The improvement was dramatic. His grades improved at school. His behavior improved at school. And the mother was sitting there talking to me. She said, "Dr. Karniski, the teacher says that he's a model student now." And I said, well, good. So what do you think of the medication now? And she said, "Well, I think he's depressed." I said, "Depressed? What do you mean? You just told me how well he was doing. Why do you think he's depressed?" She said, "Well, when he came home from school before he started medication, he would be jumping all around the room, jumping up on the couch, pulling the cat's tail. The cat would scream and he would go chase after the cat. Now, when he comes home from school, he drops his book bag on the floor, goes to his room, and he reads for 2 hours." And I said, "And why do you think he's depressed?" She said, "Well, he's never been like that before. He was hyperactive and impulsive before, and now he just sits and reads." And I said, "Well, let me ask you a question. If he had been born this way, so that when he became 9 years old, he would sit and read for 2 hours a day, would you have been concerned?" And she looked at me like I was mad. She said, "No, of course not." And I said, "Then what you're seeing is what your child would have been if he didn't have ADHD." And I think that's an important lesson to learn. Does it change personality? Yes, it does in some cases. But for the most part, the changes are positive, not negative. And for those that seem negative, we need to change our perspective sometimes, like the girl that was 12 years old and 19 years of age had a different perspective on what was an appropriate way to feel and an appropriate way to act.
I want to spend some time talking about the challenges of medicating. Our daughters were really struggling before we did start medication. But in our case, and I think a lot of families, it wasn't, here's a prescription, let's try it, and suddenly everything was better. We have been through probably a dozen medications, and that's between the two girls and even myself. There are so many of these medications. So why do doctors have this long list of both stimulant and non-stimulant medications? And some are, I guess the proper phrase would be off-label uses for ADHD. Why so many?
Great question. There are currently, at my last count, 46 medications that have been approved by the FDA for the treatment of ADHD. 46 medications. Of those 46 medications, 36 of them are stimulants. And let's talk about the stimulants first, because the stimulants are more effective than the non-stimulants. But there's a use for the non-stimulants that we can talk about later. So of those 36 medications that are stimulants, there are really only two medications, two generic substances that make up those 36 medications, methylphenidate and amphetamine. And it's kind of like coffee beans are coffee. But if you put them in a red can and write Folgers on it, it looks one way. If you write Maxwell House on it, it looks another way. If you write Starbucks on it, then the beans seem something different. But all of them are still coffee beans. The same thing with these medications. Ritalin and Concerta and Dexedrine and Adderall and Vyvanse, all of these are stimulant medications. Vyvanse and Adderall and Evykio and many other medications, Dexedrine, are all amphetamine medications. And Concerta, Daytrana, Metadate, Methylin, Ritalin, all of those medications are methylphenidate. The only difference is that one medication may last longer than another. Another medication may come in a liquid form, so it's easier to take. Another medication may come in a chewable form so the child won't have to carry liquid around all the time. Another may come in a patch. Why are there so many medications? First, because that's where the money is. Pharmaceutical companies make different mild changes to the medication. They then take it back to the FDA. They get approved for a new medication that they can now charge 10 times as much as a brand name than they would as a generic. So they do it for the reason it allows them to increase their profits. But in the process, our children have benefited because there are now so many more options. When I started treating children with ADHD, there were 3 medications used to treat ADHD. Now there's 46. And yet we still are dealing with the exact same substances that were available when I started practicing in the 1980s. I hope that answers your question to some degree.
Most of the medications fall into the stimulant category. And then there are the non-stimulants. And what are those?
The non-stimulants work in a slightly different way. There are medications like Wellbutrin, Strattera, Clonidine, Penex, Catapress. There's a number of medications in that category. And here's the difference. These medications are not quite as effective for treating the hyperactivity and impulsivity of ADHD. They do help with hyperactivity and impulsivity, but not as well as the stimulants. Secondly, they don't help with the attention problems as well. But one of the things that they do is they work at least somewhat to help mitigate the symptoms of ADHD while getting rid of most of the side effects that the stimulants could cause. So, for example, stimulants will cause difficulty falling asleep, whereas Catapress will help with sleep. And at the same time, it's helping with behavior and attention and learning during the day, although not as much as the stimulant. In addition, Ritalin and many other medications in that category cause irritability, and yet the non-stimulants reduce irritability. So in almost every case, if we have side effects that we cannot manage with the stimulants alone, and we see side effects that we can't manage by adjusting the dose or the timing, then adding a second non-stimulant generally helps improve the behavior, allow for a lower dose of stimulant, and less side effects.
I want to ask you about the importance of timing and combinations. As I said, we do work with a wonderful medical team. We have a good pediatrician. We have a child psychiatrist. We also then monitor their blood pressure, and we do all of these things. But we have found that the timing really matters with these medications. Taking some at night versus the morning, which one you take in the morning versus which one at night. So why is timing so important to a good therapeutic approach to treating ADHD with some medication?
Well, let's take Ritalin as an example. Ritalin is basically methylphenidate, which is one of the stimulant medications. It lasts about 4 hours after a dose is taken. So what happens is you take the dose in the morning at 7 o'clock. By 8 o'clock, the medication is starting to be effective. And by 8 o'clock, it gets into the bloodstream. And between 8 and 10, the child may be focused and attentive. But by 10 o'clock, the dose may have exceeded the point where side effects occur. And so the child might be too quiet or too somber at that point. So then the medication starts to wear off at 10 or 11 o'clock in the morning. And as it wears off, that's a shock to the system and it causes irritability. So we just took a child who had problems with attention and put him through 4 different psychological states in 4 hours. He went from unmedicated to appropriately medicated to over-medicated to the medication wearing off. And each of those 4 states will change the mood and the psychological state of that child. And then we send that child to the office to get a second dose at noon. And then we give them a third dose when they get home. And he goes on that roller coaster again and again. I have to tell you, I've had many parents come in and say, yes, I know my child has ADHD. I know he needs medication. I know he benefits from medication, but I don't want to turn him into a zombie. Or what will happen to him if he stays on this medication all day long? And that's why timing is so critical, is that if I give that second dose of medication at 10 o'clock, then I'm going to be increasing the side effects because that's at a time when the level is high from the first dose. If I wait till 2 o'clock to give it, there's going to be a lot of irritability between 11 and 2 because the medication has worn off, and it causes irritability for the half hour that it wears off.
You could see how a parent gets overwhelmed.
Yeah, exactly.
As a parent, you're sitting there, you're seeing your child go through this emotional roller coaster of really great focus and then absolutely no focus, high mood, low mood. This would explain some skepticism towards the medication is if you try it and you don't work with the medical team carefully, you're seeing your child just go through this roller coaster of emotions. And you start to say, gee, I just don't want to do this to my child. And that's where someone, as you're mentioning, you want to step back and say, okay, well, how can we even this out? So how do you do that? How do you make it so the poor child or even the adult with ADHD isn't going through this euphoria? Wow, I'm focused. I'm great. Oh man, I feel horrible. Oh, good. I'm back. That is so exhausting to go through those stages throughout a day.
In the first place, I think it's important to use a long-acting form of the medication. And that's what the pharmaceutical companies have in their pursuit of profits, have also given us the gift, long-acting medication. So take Concerta, for instance. When Concerta came around in the turn of the century, about 20 years ago, it was a life changer for many kids. Because Concerta takes about a half hour to an hour to take effect, but it lasts 10 to 11 hours. And when it wears off very gradually. It actually wears off over a 2-hour period. And as a result, it prevents all of those ups and downs that were occurring from the short-acting medication. It prevents the irritability when the medication wears off in the afternoon because the irritability is caused by medication wearing off too quickly. It wears off very gradually with Concerta, and that allows it to just take the child off the medication without causing the irritability. And what's in Concerta? Nothing but methylphenidate, the same ingredient in Ritalin. But the difference is dramatic.
And that's why we have to test all these different medications with our children as we're trying to find that right medication that has the benefits without the roller coaster.
Exactly. It behooves us to find a physician who asks the right questions as well. And the right questions are about what is your lifestyle like? So for a 6-year-old child that's on medication, we might want the medication to wear off by 4 o'clock so that he can eat a good dinner. But for the adolescent who has tennis lessons after school and then sees a tutor at 6 o'clock and then studies till 11 o'clock, that child's going to need a longer acting medication. So what is important for the physician is to take a very thorough history to determine what the needs of that individual child are, and then structure medication dosages and timing to meet those needs appropriately. So one medication lasts 8 hours, another lasts 14 hours. Daytrana is a skin patch that lasts 24 hours if you leave the skin patch on long enough. I found that to be highly effective in college students. On Tuesday, they might be done by 12 o'clock and they'll remove their patch at 2. But on Thursday nights, they may study till 2 o'clock in the morning. So they'll get 16 hours out of the patch one day and only 10 hours the other day because they remove it at different times. Timing is the key.
And I hear you voice a little bit of skepticism towards the pharmaceutical industry. Yes, they're motivated by profit, and we're just fortunate enough that profit motive helps us by giving us things like the timed release. So it's interesting to me that you are a little bit skeptical of their good intentions, and yet you also recognize that there's some positive coming from this.
Absolutely. And very positive results. I mean, the world is so different for me now as a physician seeing children with ADHD than it was when I first started in the 1980s. I had very few options. And I had basically Ritalin and Dexedrine, and I only had the short-acting Ritalin, none of the long-acting preparations. Dexedrine is an amphetamine. It works the same way that methylphenidate does, but it has a different side effect profile. It's more likely to cause appetite problems and sleep problems. And so we generally start with a methylphenidate-based medication. The beautiful thing about it is we have so many different options. I actually have on my website an interactive tool for physicians so that they can click on on a button that says, show me all the long-acting medications, or all the long-acting medications that come in liquid form, or all the short-acting medications that come in a capsule, or show me all the skin patches that are available, or show me all the non-stimulants. And the tool will actually then give you a list. Each time you click on one or the other, it'll give you a list of medications that meet those criteria. Each physician uses something similar to that.
As a parent, one of the things I want to do is minimize the amount of disruption that occurs even taking the pills. We have a calendar with our morning doses, our afternoon doses, our evening doses. Like so many households, it's like 6 or 7 pills for different things scattered throughout the day for each of my daughters. How do we manage this effectively with our physicians, with our psychiatrists? How do we help them help us, where we can say, look, this is too many, or how can I decrease the complexity? Because when it's this complex, I'm going to make mistakes. Even as a parent with a checklist, I'm going to make mistakes. So how can we help our physicians help us?
Great question. And I think that really is the $64,000 question. How can we use the time that we have with our physicians, educate them about our children, is really what the question is. And what I would first say to parents, I think there's a lot of answers to this question, and I actually have an entire chapter in my book addressing that question specifically. I think the one thing that a parent can do is understand that there are 4 important time periods throughout the day when you're dealing with medication. It is critical that the physician knows when the side effects are occurring in each of those 4 time periods. So the 4 time periods are the following. First time period is the period of time when a child is off medication. So if a child's taking a dose at 8 o'clock in the morning, what's he like between 7 and 8? The second time period is what happens when the medication reaches its peak effect. Is it effective, or are there more side effects at that point? The third time period is what happens when the medication starts to wear off. And that usually is only a half hour or an hour. And that period of wearing off can lead to irritability that's not present before it wears off and after it's worn off. And then the fourth period is what happens when the medication is completely worn off. So for instance, if the medication is completely worn off, but a child's still having difficulty falling asleep, it's not the medication's fault. It probably is the result of the ADHD, and we need to address that symptom differently, and maybe not from a medication standpoint, but from a behavioral standpoint. But if you go into your physician's office and say, my child's irritable, that makes the job of the physician, his job then is to pull that information out of you. And he may not have that time to address that. So if instead you go in and say, when he takes the medication in the morning, all of a sudden at 9 o'clock, he seems like a different kid. He's focused, he's alert, he's responsive, he's in a good mood. But at 10:30, we start to see this irritability, and we see it again at 4 o'clock. Then we know it's due to the medication wearing off, and that child needs to be on a long-acting medication. So providing the physician with information about those 4 time periods is critical.
What led you to write the book, especially with the title, ADHD Medication, Does It Work and Is It Safe? That sounds like, the very questions I have when I first went to the doctor with my daughters. Will this work, and is it really safe to be giving to these young minds? What led you to write this book? Was it parents like myself? Was it concerns for, about how other physicians were experiencing these interactions with parents? What motivated you?
Well, the answer to the question is yes, it is all those things. But I have to tell you what happened with me is one day I was looking for a book on ADHD medication. And I wanted to learn, this is after I've been practicing for 20 years, and I wanted to learn more about some of the new medications that were available. So I went to Amazon, and I did a search on Amazon for ADHD medication. 300 books came up, but they were titled like How to Help Your Child with ADHD Do Homework. ADHD in adults, how ADHD affects your marriage. What are the behavioral treatments for ADHD? In other words, I went through 40 or 50 different books that had been published on ADHD, and not a single book had been published on the topic of how to manage the medication issues. Yes, many of the books had chapters in there about medication, But most of the time, it did not go into the depth that I felt it was necessary to really help parents understand. So that's why I wrote the book. Now, I understand that talking about chemical formulas and medications can be pretty boring, especially for somebody that's not familiar with the field. So I've done one thing to help with that, and every chapter has 2 or 3 stories that point to the behaviors that we're trying to address in that chapter or in that section. So in other words, I start out with a story, then explain what happened in that story. And I think I tried to make the stories generic enough. Most parents will have experienced one of those situations.
In your background, you are a developmental pediatrician. We have seen neuropsychologists, we've seen neuropsychiatrists, we've seen a psychiatrist, but a developmental pediatrician is not a title we have encountered as parents. So how does that training and that background differ from what many of us have seen as parents? What is a developmental pediatrician?
First place, I'll tell you, there are a few excellent programs in the United States for training physicians after they become physicians to specialize in developmental pediatrics. But there are very few developmental pediatricians across the country. I would venture to say that we're talking about an order of hundreds rather than there's thousands of pediatricians, but only a few hundred developmental pediatricians. And there might not be any in your city. So what is the difference between a developmental pediatrician, a psychiatrist, and a neurologist? Theoretically, the neurologist pays attention to the neurology of the child, what's going on in the brain and so on. And the psychiatrist pays more attention to what's going on emotionally with that child. As developmental pediatricians, maybe we're patting ourselves on the back too much, but we see ourselves as being somewhere in the middle, and that we understand that both neurology and environment play a role in shaping our behavior. So the way that our genes are put together, whether it causes ADHD or just a different personality, affects our personality. But our personality is also affected by the way we were raised as children. So developmental pediatricians recognize that both of those factors are of equal importance. And in some children, the neurology is more important. In some children, the environment is more important. And in some children, both are critical.
And so this informed your perspective when writing this book. Is you're writing about this artificial separation of mind and body, but you're talking about the neurology, the psychology, and the general pediatric condition of the child.
Absolutely. Yes.
And this book is broken into very specific topics in each chapter. You said you started writing the one on side effects first because that was so important to parents and to providers. What are some other important topics that people will find as they go through this book?
Well, the first chapter, I go through a little bit of a description of how a physician makes the diagnosis of ADHD. Second chapter is a unique chapter in that one day I was talking to a mother. She was talking about her child who had probably having ADHD, but it was the first time I had seen her. She started to cry as she was giving me the symptoms. And because she couldn't talk anymore, she handed me a notebook. And in the notebook were the conversation that occurred between her and the teacher every day of the week. And it went on for a year. It was a calendar where the mother wrote a note and then the teacher wrote a note, and then it went back and forth. And the frustration that was seen in the parents is described throughout the second chapter. And as a matter of fact, I reproduce about 8 or 10 of those pages from the notebook and talk about how that child experienced his ADHD in the classroom. Third chapter is the history of ADHD medications going back to the 17th century in Japan, and how the medications got their name, how they developed, what the pharmaceutical companies did with them, and so on. One chapter is on why there are so many different medications to treat ADHD. How does a physician make that decision? The side effects of medications. And if obviously the physician makes that decision by comparing the effectiveness to the side effects and taking a medication that is effective with the least side effects. And then finally, at the end of the book, there are 3 chapters in which I take about 2 or 3 pages and describe each of the 46 medications in some detail so that the parents will understand what each of those medications is doing. So I don't expect parents to read all chapters on every one of those 46 medications, but they now have a reference to look up. My doctor wants to start Metadate. Let me see what Metadate is and why he wants that particular medication. Whereas the doctor may only have 15 minutes to talk with you. You've got the book in front of you to take as much time as you want to answer questions for yourself. What is this medication doing? How is it different from all the other medications?
Dr. Karniski, it has been such a pleasure to talk with you about ADHD medication. Does it work and is it safe? It's available everywhere, published by Roman and Littlefield. And I hope the listeners have learned a lot from our conversation. I really thank you for sharing your knowledge with our audience.
Chris, it's a pleasure, and it's been actually quite fun as well. Your questions clearly come from a background of somebody who understands the problems that we as physicians have to deal with every day when we're treating children with ADHD and autism.
These were all struggles I went through and that you have really addressed today during our conversation. And for listeners, in your book, you discuss, as you mentioned, the side effects, but the benefits too. It is, in our experience, we are finding these are perfectly safe. You just have to work with the physician, with the psychiatrist. You, as a parent, have to be part of a team supporting your child. You have to go in prepared with notes and say, at noon, my child seems to be very down and slow. Is this normal? Or at 7:00, she doesn't want to go to bed and is hyperactive again. Do we need to adjust something? In your book, you talk about this, and you talked about it today in our discussion. And that's really what I hope listeners are leaving with is this is a team approach that parents have to take with physicians.
Exactly. I want to emphasize that I didn't write the book to turn parents into physicians. It's not the parent's job to have to know all of these things. But the problem is pediatricians have to be experts in COVID. They have to be experts in ear infections. They have to be experts in low birth weight premature children. They have to be experts in prescribing birth control pills for a teenager. They can't be an expert in every aspect. They can't be an expert in multiple sclerosis, ear infections, appendicitis, and ADHD all at the same time. I think it is the parent's job to make sure that the physician is armed with all the ammunition that he or she needs to address the problems that are appropriate in this case. And parents understand that their child is unique. Pediatricians tend to lump children together, and they need to be able to understand, oh, this child has an ear infection where the eardrum has been perforated. We treat with this particular antibiotic and over this period of time because the research has shown it to be most effective over that period of time. With 350 studies published every year on ADHD, it is hard for a physician to keep up with that. So I think the physicians, the pediatricians today are so much better informed about ADHD than they were 40 years ago when I first started practicing. But they're not necessarily experts in ADHD. And while they may be appropriated in handling half of the children who have straightforward ADHD, the other half have complicating features that should be addressed by a specialist.
Again, it's been such an honor to talk to you, Dr. Karniski. I cannot thank you enough for joining us on Perspectives on Neurodiversity. I have learned so much just talking with you, and I hope that listeners have learned a lot listening to us.
Thank you, Chris. I can't tell you how much I appreciate that.